Hello and welcome back to our Plum Health web series. We're talking today with Jonathon Trionfi of Plante Moran, and he's a benefits advisor. So he helps groups buy insurance to take care of their employees, but I don't think a lot of people know specifically what that is. So I'm going to let you color those lines in and tell us a little bit more about what your role is and how you help companies and employer groups and employees live healthier lives.
Sure. Thanks for having me. I appreciate it. Just a little bit about me. I'm a 20-plus year professional in the benefits consulting space. I've been doing this my entire career. I'm a partner with Plante Moran, Group Benefit Advisor, so we're an entity of Plante Moran, and been there for about 17 years or so. And really, to your question about what it is we're doing, big picture-wise, really what we do is exactly what you said. We help our clients, employers, typically in the middle market with employee numbers of 50 to call it a couple thousand employees. We help them procure insurance, health and welfare insurance, so that'd be like medical, dental, vision, life insurance, things like that, and help them create strategies on how best to deploy those benefits for their employees, both to address costs, competitive compensation, total rewards, that type of thing.
Yeah, so this is a deep question. So we've seen health insurance costs go up by 10%, 12% on average, year over year over year, and it feels very unsustainable. So can you talk about why are we seeing this explosion of costs, and are we failing the American workers and American people by putting this burden onto their employers and onto their paychecks?
Yeah, so that is a very deep question, and it's one that there are a lot of whys behind that. And really, when you peel the onion back, to me, it all comes back to the incentive structures that exist in healthcare. There are a lot of misaligned incentives when it comes to healthcare and health insurance. So when I take a look at that, the 10 to 12%, as some people go back to the Affordable Care Act, right? So one of the things that we know in the Affordable Care Act are things like the medical loss ratios that don't get a lot of attention in the press and things like that.
The medical loss ratio, what's that?
Yeah, medical loss ratios effectively govern the margins for an insurance company.
Right. That's that 80-20 rule where they got to spend 80% on care and 20% on margin.
Right.
So let's make the pie bigger so the margin's bigger, right?
Exactly. So, and then for larger employers, that split is 85-15, right? So it differs by the size of employer. But that's exactly right. So there's an incentive for insurance companies. Most employers think that the insurance companies have an incentive to keep costs down, but the insurance companies are really balancing that, right? They have their own interests. A lot of them are publicly traded, so they have an interest to the shareholders. So they're really balancing that so that there's that conflict of interest where the insurance company wants one thing and the employer wants another. And that can be difficult for an employer to navigate that.
Yeah, I would call that a perverse incentive, right, on the insurance company where they're spending more money to make more money themselves.
Correct.
And then as a doctor, as an individual that's really invested in the healthcare system, you often see inflated prices on the hospital side to justify those larger bills.
Yeah.
And it almost feels like collusion. I don't know. Correct me if I'm wrong.
No, it's interesting. Plante Moran, so we're on my team is on the benefits side, but Plante Moran, serves and consults on the provider side as well. So we sometimes compare notes, and it's very interesting, the idea of payer mix and things like that on the provider side and how to balance that.
Right.
But yeah, there's all sorts of, again, maybe misaligned incentives on that side of the aisle too, when you think about referral rates and stuff like that. And
yeah, so I think for our audience, we should say doctors are incentivized to refer more of their patients to higher cost specialists because it costs more money, it makes the hospital more money, but ultimately it's not great care for the individual because the primary care doctor, the family doctor could be doing that.
Right.
And it's not good for the patient because it costs them a lot of time. A lot of times to see a specialist, it could cost you 3 months of time or 2 months or 4 months, right?
Yeah, and that was a big aha moment for me when I was younger. It was probably a couple years after I I graduated. I went for my first adult physical,
Yeah.
and I talked to the doc for maybe 10 minutes, if that. And I walked out doing what I do, and I said, that seems very odd. How is the doc really supposed to get to know me or really evaluate my health in 10 minutes? And that's when I kind of started my journey of asking maybe questions I shouldn't be asking.
Sure.
But it was really that moment where I said, something's not right with our health system, both on the insurance side and the healthcare side. And that's, again, like when I really started to start asking those questions.
Yeah, because for our audience on background, like most insurance-based doctors have 2,400 patients. They have to see 1% of their panel a day. So that's 24 visits a day. And so that means 20 minutes per patient in an 8-hour working day. And that's why your doc can only see you for 10 minutes face-to-face. And then you got to spend 10 minutes typing everything into the EMR. And a lot of people have that same sensation of like, what is this? I thought this was supposed to be an annual physical.
Yes. Yeah. And I've experienced that too, you know, with the referrals, and it's like, do I really need to take more time out of my day? I'm busy. I'm doing a lot at work, and okay, so now I've gone from one appointment to 2 appointments, and then getting scheduled with a specialist isn't always the easiest thing to do in terms of their availability.
Right, and then you got to balance their availability with your schedule. I don't even know what I'm doing in 4 or 6 months from now, right? How am I going to schedule that, right?
Yes.
And then you got to take time away from the office and go see them, and so you're losing productivity.
Yeah.
So I'm assuming that you've discovered direct primary care along the way at some point. Did you find it as an individual or more of like market research as a part of your job?
Yeah, so I heard about it quite a while ago, but you're the one that introduced me. You were the first direct primary care doc that I met, and that was, we were talking about it earlier, like 8 years ago.
Yeah, 2018 maybe, 2017.
You came into the office and were explaining it to me, and I'm like, I think this is how primary care should be. This is the model that should help address some of those things I mentioned earlier about, you know, the doc getting to know the patient getting to know the doc, you know, that reciprocal type of relationship.
Yeah, access to care, time with the patient, et cetera. So, as a broker, you know that that's the way it should be, but I know there's so many barriers between that actually happening. So what are those barriers between, you know, people going from the old health insurance model that's clunky, not enough time with doctors, to getting more people into the direct primary care world?
Yeah, I think there are a number. I think the first one, employers, there's a certain sense of safety with an inertia that's really tough to break. And so that's the first thing. The second thing is that there can be an inherent mistrust between employer and employee. And I think we all feel that some of that mistrust is increasing, not decreasing.
Yeah.
And so if an employer develops a relationship with a provider, is the employer going to think that the employees will not use that doc because of the mistrust by their employees? And is this really something that's good for me? So I think there's a general sense of concern that it might be a lost investment or an ineffective investment. And then I think the third thing is that the direct primary care model, probably up until just recently, especially here in Southeast Michigan, has not lent itself well to integrating with the employer's health plan.
Yeah.
And what I mean by that is, you know, a lot of employers have multiple sites. So is it a solution or a benefit that can be offered to everybody, or is it only a benefit that can be offered to people that live in and around the office, the DPC office?
Yeah, and those are great questions. Those are great challenges that I think we are overcoming as more and more doctors are adopting this direct primary care model. You know, we have 5 sites in Michigan, and we have many doctors waiting in the wings that want to join us. But there's that chicken and the egg issue where we can only hire more doctors if there's enough patients to meet that demand. And then you're kind of stuck in limbo waiting for more people to join. So
And I think that's a really important point. I think more employers need to be hearing that point exactly about doctors wanting to practice this way.
Yes.
So I think most employers are going to say, I'm not an expert in the medical field, right? I don't know how doctors want to practice. I don't know what motivates a doctor, that type of thing. But if employers know that there are doctors out there waiting and wanting to work this way, some of those barriers may come down, or some of that resistance may come down from employers to say, okay, if the medical community wants to do this, let's play our part.
Yeah. So for our doctors, we only need about 500 patients to have a successful, thriving practice. So if you had an employer group with 500 or 1,000 people, we could easily set them up with like an on-site or 2 on-site doctors or near-site, depending on what the agreement is, to support their employees and take care of those employees. And that could be done in a relatively short time span, like 3 to 6 months or something like that. And I don't think, that's a huge barrier in my perception, is that there's not a lot of education around direct primary care. And I'm going to flip this to the broker side.
Yeah.
Can you talk about maybe some misaligned incentives on the broker end where, there's a bit of a commission that comes from insurance companies to sell the plan? I don't think a lot of consumers, employees, employer groups are familiar with that concept.
Yeah. My side of the industry is not innocent, so to speak, in that regard. I think there's a lot of misaligned incentives for us as well. There's a saying, you work for whoever pays you.
Indeed.
So if the insurance companies are paying people like me, I think it's safe to say, are we working for the employer, or are we working for the insurance company? And that's a really important distinction to make, because it really puts people like me in our industry in that position where, are we really serving two masters, so to speak? And that's hard. That's a delicate thing to balance.
Yeah.
It also opens us up to criticism to say, are you providing me, the employer, advice that's in my best interest or your best interest? And that, if you're not working the right way, that can be a really difficult question to address when it's posed to you by an employer.
Yeah, and insurance commissions to brokers is one thing, but there's also, I see that as a physician, for doctors operating in the insurance-based world, we're not blameless either, right?
Yeah.
Like, our customer is the insurance company when you're operating in the insurance-based world, right? Our whole EMR system and the whole way we do visits on volume is based on satisfying the needs of the insurance company, and the patient is just a conduit for receiving those reimbursement dollars from insurance. So I think there's plenty of blame to go around here.
Yeah, and to me, when you really think about insurance, and this, I'm sorry if this gets a little too nerdy, but
No, this is great.
in many ways, there's nothing wrong with the traditional insurance model, right? Insurance is meant to protect against catastrophic financial loss, right?
That's correct.
When I think about insurance, I'm not thinking about how do I cover the annual physical, or when I have to take one of my kids into their pediatrician, like, the oil changes, right? We don't add oil changes to our car insurance.
Indeed.
We don't. Home insurance doesn't cover new windows
Or
right?
new paint, or
Exactly.
new locks on your door, right? Those are all primary care things for your house or
Right.
for your car.
And I think if the insurance model in the medical space were to revert or go back to that type of model, and we could deal with cash pricing, membership-based arrangements where the relationships with the docs can be more meaningful, it really changes the dynamic of that part of the healthcare ecosystem, right? So that's where I think that there can be some really real meaningful change. But the inertia, the status quo, and frankly, the amount of money, right? I think I read we're at like 17, 18% of GDP is healthcare in the US.
That's insane.
Just think about that. To upset that model
Yes.
could have some pretty consequential ramifications for our economy. So there's a lot to overcome.
Yeah, let's talk about that inertia. 85% of the market in terms of health insurance is controlled by one company, right?
Yes.
And getting around that juggernaut is really difficult when it's essentially a monopoly in Michigan. So how do you start to chip away at that? How do you get people to think differently? What are some strategies that you've employed to open people's eyes to direct primary care or other alternatives to reduce that 10% or 12% or 20% increase that employer groups are seeing every year?
Yeah. So I think first and foremost, it's about educating the employer about what's driving their costs. Okay, you can't address a problem until you know what the problem is to begin with. So first thing is educating them. What's driving your costs? And the idea behind going to market and bidding this out, that's not a solution. This isn't a commodity purchase. If we were talking about pure insurance, it might be a commodity purchase, but it's not. So the first thing is education. And then the second thing is really changing the financing of a health plan. So from my perspective, I'm a big proponent of self-insurance. And the reason for that is how an employer takes back control.
And you mean like self-funded plans. So the company basically owns all the costs for their employer health for the year, and it's often less expensive than buying health insurance through Blue Cross or Cigna or Aetna or United?
Right, exactly. So and you can self-insure with any of those large insurance companies. But right off the bat, you're going to take premium taxes out if you self-insure. There's some other advantages, like when you're self-insured, you have the ERISA exemptions, so you don't have to comply with many of the state mandates, especially if you have employees in different states. You can kind of create a more homogeneous benefit offering for employees. But the idea is the employer assumes all of the risk of paying for the goods and services in the healthcare arena that their employees and the employees' family members are consuming. Yeah. And then most employers, other than maybe like the enterprise size groups, they buy stop loss insurance in order to protect themselves in the event of a catastrophic event, or hiring a new employee that has a really significant medical condition, or a family member that has a really significant medical condition. So they buy that stop loss insurance to protect their financial interests.
Yeah, and what's been amazing with our journey over the last year with Plum Health, we've been able to work with some employer groups with 200 or 150 or 300 employees, namely some school districts in mid-Michigan, and many of them are self-insured like that, or fully funded, taking care of their own policies or the performance of their own policy, and they use Plum Health to give excellent primary care to all of their employees. We can take care of 90% of their healthcare needs, and we have the time and capacity to see those complex cases, to not refer those out, and it ends up saving them 10, 20, 30% on their health insurance spend for the year. That saves them a tremendous amount of money.
Yeah.
My question is how do other companies not see that? Or how can we do a better job of telling that story or communicating with employer groups that this is possible?
Yeah, so I think first of all, you probably feel it might be kind of where you were going with some of the questioning, but the broker community has an incentive to keep the DPC model really out of the equation, right? It doesn't fit. It's by reducing costs. If commissions are a function of cost, you can see the commissions are going to go up as the costs go up.
Yeah, so that's a dark side of this conversation, but we should have it. What's a typical? Is it a percentage commission of all the insurance spend for the year? And can you talk? Give us some hypothetical. If you have an employer group of 500, how much are they spending on insurance, and how much is a commission for a typical broker?
Yeah, the commissions can vary anywhere from 2% to 4%, depending on the size of the group. So on a fully insured basis, and it is percentage based. So again, I always tell employers that I'm talking to, if you get a 17% increase, and the commission is a percentage base of the premium, your advisor just got a 17% raise.
Yes,
and that.
Employees don't see that.
No.
Employers don't see that. And we've talked about this before. It's when your insurance rates go up by 17%, that's a bonus not given. That's Correct. A raise not given. that's an investment in the business that business owner is unable to make because they're spending all of that margin
Correct.
on rate increases. So throw me a number. If I have 100 employees or 200 employees, what's the typical insurance cost for, let's say, 200 employer group?
Well, it depends on what they're buying, but I would say in terms of commissions, the traditional insurance broker is probably going to, for a 200 life group, is probably going to be looking somewhere between $80,000 and $100,000. That's what they want their compensation to be, right?
For the year.
For the year.
$80,000.
Correct.
To tell them, buy this Blue Cross or Aetna or Cigna or United plan.
Or here's why the 17% increase is a great deal for you. Right.
Indeed. Yeah, we went actually to an insurance broker conference earlier this year, and one of the brokers got on stage and proudly described that conversation. I delivered a 36% increase to my employer group this year, and I helped them understand why that was a great thing for them.
Yes.
And we were in the back, like pulling our hair out, like, are you kidding me? How is this a good thing for your employees, for the employer, for anybody that's a part of this deal?
Yeah. So, yeah, it's a frustrating thing being on that side of the aisle. Like, I get frustrated that, our industry, we need to do a better job of becoming more educated, being students of the game, so to speak.
Indeed.
We need to learn more collectively about how the system works, not just the insurance side of the house, but the healthcare side as well, so that we can give better advice to employers.
Yeah.
But part of that advice, you ask the question, like, how do you get the message out? I think part of that messaging is don't look for the perfect solution. Okay.
Yeah.
There is no perfect solution. If there was a silver bullet in healthcare and health insurance, every employer would be doing it. There's no such thing. But if you can find an 85% solution, why aren't you going to jump at that? So that's like some of the objections that I get from employers when talking about DPC. Back to the point about geographic differences.
Yeah, let's talk about that, because here in Michigan it's very frustrating.
Yeah.
As a direct primary care doctor, I'm watching states like Kansas and Florida where they've had skyrocketing engagement with employer groups around direct primary care. Why do you think Michigan's such a laggard on this aspect?
I think this one I'm going to put on the employers. So I think employers have to start asking for it. It's the employers. They're the ones that are the consumers, right? They control the demand. So if employers start asking for different solutions, like, hey, these cost increases are not sustainable. We don't need to nibble around the edges anymore.
Yeah, what else can we do?
We really need to sink our teeth into this and come up with a strategy.
Yeah, it's time for a paradigm shift, right?
Exactly. And that's the type of thing that has to happen on the employer side. And when the demand goes up, I think, being an economics major, I truly believe the market, and like you said, there's docs waiting. So the supply is there. We just need the demand to catch up.
Yeah, and so I really think it's about educating employer groups, but do you see any other barriers to like helping accelerate this growth of the direct primary care movement, direct primary care model in Michigan?
Yeah, I think there's always that fear of being the first. Is there critical mass? I mean, even at Plante Moran, we have a saying: we like to be fast followers, right? We don't necessarily like to be the first, but we're going to follow pretty quickly when we see something that's effective. And I think that's probably not dissimilar from a lot of employers that say, I'm not ready to be the first. I'm not a trendsetter.
Yeah.
Right? So I think there's that finding the first, and finding the first that is willing to be vocal about their experience and the success that they're seeing and the benefit that their employees are seeing in terms of their health and things like that.
I really feel like the rate increases that people are getting from the BUCAs, Blue Cross, United, Cigna, Aetna, are getting so high year over year that we're going to hit some kind of unsustainable tipping point where this is unsustainable for employers and employees, and people are going to be actively looking like, hey, we got to do something right now. Do you think we're close to that tipping point, or where do you think we are there?
Yeah, I think we're there. I really do. So this year as our group is going through renewals for 2025, calendar year 2025, you can feel it from employers. It's like, when is this going to end? Like, this can't keep going on. And so I think we're there. And I think then it's a matter of responding or making sure that they're aware of the solutions that exist. And it's not just direct primary care. I was talking about self-insurance, and when you self-insure, you give yourself the flexibility to deploy solutions or really develop a strategy.
Yes.
No different than other aspects of the business. You know, you look at these business minds and you're like, gosh, these folks are just brilliant. They're so well thought out, strategic. They put great plans together. And then when it comes to healthcare, health insurance, it's like, I just don't want to be bothered with it. It's too frustrating, that type of thing. But if we can get those minds to use those skills towards creating strategies, I think employers are going to be the beneficiaries. I think, folks like you will be beneficiaries too as they learn about the TBC model and how it can help their people.
We hope to help as many people as we can. Yeah, and to your point about a stepwise approach, I was speaking with a business owner, former CEO of an accounting firm with 120 people in Chicago, and essentially he was all in on direct primary care 7 years ago, and it took him 5 years to get his company to that point where they integrated like a mail order pharmacy. They integrated some other services to lower their overall cost spend after self-insuring. And it was only after a lot of education were they able to flop over to direct primary care. Yeah. And so I know that there's kind of a stepwise or tempered approach that employer groups can start taking as well.
Yeah. And when you look at that, sometimes we call it the crawl, walk, run.
Indeed.
So if you start, the first thing you have to do is change the plan financing, right? That's because without it, you're not really positioning yourself as an employer to be the beneficiary of deploying those different types of solutions.
Change the plan financing as going from fully insured to self-funded.
Yeah, accepting that risk back from the insurance companies.
Indeed.
Okay, so that's step one. That might be the crawl. But there's some risk management concepts that you might want to integrate into that crawl phase. Mm-hmm. And then the walk phase is, what do we do about pharmacy costs? That's usually low-hanging fruit. I mean, I think we all know there's...
The PBMs are really taking advantage of people.
Yes, and there are really effective solutions out there for employers to consider, a lot more transparent with some of these new lawsuits, the ERISA lawsuits that are coming out, with Wells Fargo and the Mayo Clinic, Johnson & Johnson. I think that employers are going to start to take notice of how do you address the pharmacy costs. So that's kind of low-hanging fruit. But then you can also get into voluntary type benefits that can help the end user, the patient, become a better consumer of healthcare.
Indeed.
So like one of the things that we do with a lot of our self-insured clients is we deploy solutions around schedulable surgeries and schedulable imaging, right?
Indeed.
So we know if you need an MRI, you can either go to the hospital and get the MRI
for $3,000.
Exactly. Or you can go to, up the road, Basha Diagnostic
or regional medical imaging.
RMI.
That'll be $300.
Exactly. And so can we develop an incentive model to get people to become better shoppers of healthcare services so that they understand that they have more control in those decisions than they may have thought before? And we do that by using cash pricing. Yep. So, hey, let's bundle the price of schedulable surgeries. Let's bundle the price of imaging, create a cash price for those. And then it helps the provider too, because they're not chasing a receivable from the patient and things like that. So there's some win-wins there.
And a 90% savings for the employer group when they get that right. Yeah. And one of the things that we proudly do is we work in concert with that, where we are directing people to the RMIs and the Bosch's of the world for those scheduled low-cost MRIs and CT scans and X-rays.
Right. Yep. And that is so if we take a step back, a lot of the solutions that I was talking about after self-insuring, so in that called walk and then eventually into the run phase, the biggest barrier is meeting the patient at their point of need, right? So an employer can throw all these solutions at their employees and say, look at all these great benefits that we're deploying. the average employee is likely not going to commit every single one of those things to memory and truly understand when they should be using each of the components of their benefits.
We call that point solution fatigue.
Yes.
Right? There's so many of those gosh darn point solutions that nobody can keep up with them. The great thing about Plum Health and our direct primary care work is that we coordinate all of those point solutions and we make it seamless and understandable for our patients.
Yes. And that's what the patient needs, is they need that navigation, they need that steerage to say, this is when you want to use
X,
enter
Y, and Z.
point
Yeah.
solution here, you know.
Exactly.
And if they can get that type of feedback and advice, the likelihood of them using those point solutions goes way up.
Sometimes it comes with a $50 Amazon gift card or whatever when you use the scheduled MRI versus the hospital MRI, right?
Yeah.
And so some employer groups are forward thinking in that way and kind of incentivizing those smart usages.
We have a client located downtown.
Okay.
Options there outside of the major health systems are a little bit more limited. So to get people to consider the ambulatory surgical centers, the standalone imaging centers, that type of thing, they've put incentives in place to use those providers.
Like a $30 gas gift certificate or something, gift card?
It's actually just a return, a taxable
that's
piece
great.
of compensation in their paycheck. But then what they'll do is they'll reimburse the person so if they need to get an Uber or something out to the suburbs,
Yeah, Royal Oak. Yep.
they'll actually allow that Uber cost to be reimbursed.
That's beautiful.
Yeah,
That's
so-
somebody who really knows the ins and outs of healthcare costs, and they know I'd rather pay the $30 Uber ride than the $3,000 hospital bill that's artificially inflated.
But you know the great part about that? It's not just that they understand the financial component of it. They're doing it because they care about their employees too.
Amen.
Because back to your point, they know, what can I do if collectively we get that steerage? What can I do with raises?
Yes.
What can I do in terms of putting some of that money back into the community?
Yeah. Bonuses,
exactly.
donations, raises. It's
Yes.
all been tamped down by these health insurance increases.
Yes.
Well, this has been an amazing conversation, Jonathan. Thank you for sharing your knowledge, wisdom, insights. Do you have any closing thoughts?
No, I just, I think this may sound Pollyanna-ish, but, I think it's going to take all of us. It's
Yes.
going to take, so I always say that there's healthcare, health insurance is a four person partnership effectively. You've got the insurance companies, you've got the employers, you've got the providers, and you've got the insurance brokers.
Yep.
Those four
I
entities.
think we're missing one big one, the patient.
Yeah,
right?
the patient,
We're
right?
gonna
So
add
on
that
the-
into the
yeah. But on the insurance side, right?
Yeah,
So
exactly.
the employer-based insurance. So we have to get those four components aligned
Yeah,
for the benefit of the patient.
indeed.
And it's going to take some self-sacrifice. It's going to take some self-reflection to say, am I contributing to the problem or am I contributing to the solution?
Yes, a lot of self-reflection indeed. Okay, so you mentioned this ERISA lawsuit. I think we should talk about this a little bit more. Isn't there somebody who's supposed to be protecting the employees or the employer? Isn't there supposed to be a fiduciary involved to protect those sort of issues?
Yeah, absolutely. I think that's an issue that there hasn't been a lot of enforcement of. You see it a lot on the 401k side. Haven't seen it a lot on the health and welfare side, but there are individuals at every employer that are the fiduciaries of a health and welfare plan. Fully insured, self-insured, it doesn't matter. But they need to be acting and serving and overseeing the plan so that the plan assets are being used for the benefit of the plan participants.
The
which is
employees and the employer, right?
Exactly, the employees, the employer, the employees' family members, right?
Yeah.
So I think part of the issue is if again, we take a step back and look at the broker relationship. A lot of employers are relying on the advice that is coming from their broker as to what they should do with their health plan. In the event that those fiduciaries are ever named in a lawsuit and part of their defense is, hey, I was taking advice from the expert. The organization that I rely on for advice, but then that organization has a conflict of interest in the way that they're compensated.
Ugh.
I would imagine that I'm not a lawyer, but I can't imagine that's going to be a very strong defense. when the lawyers get at it, right? I think there's some hidden risk and exposure for employers that they may not be aware of or may not have really thought through yet. And that's where I have concerns for even my own clients, because a lot of employers have fiduciary committees and whatnot, again, around their retirement plans, not so much around their health and welfare plans.
Yeah, and can you spell out, ERISA, what it means and what those lawsuits were and how it affected those companies involved?
Yeah, the Johnson & Johnson and Wells Fargo lawsuits are kind of mirror images of one another. It really has to do with pharmacy costs, which is very ironic that Johnson & Johnson...
Very ironic,
right?
yes.
So it's all about, like one of the drugs that was listed in the J&J lawsuit is Obagio.
Okay.
And after that lawsuit came out, I've actually used it in some of the discussions that I've had with employers. I say, pull out your phone, pull up the GoodRx app, and just put in Obagio. And you can see at certain pharmacies that drug is being dispensed at like $20. And others, it's $4,000 or $5,000.
And Johnson, the insurance company was passing on a cost of $4,000 and $5,000 to Johnson & Johnson for a drug that should actually cost $10 or $20.
Correct.
Yeah, so that's wild.
But
not shocking, right? Like, everybody knows that the costs are inflated and it's hard to cut through and fix this problem.
Yeah, and I think the counter argument to that is, okay, well, that's just one drug. You're kind of cherry picking a drug. The truth of the matter, though, is that there is a lot of fat, so to speak, in the pharma space. I think, Mark Cuban's been talking about it a lot recently in the news. Based on anybody that'll listen to him, right? He's kind of championing. There is exposure. I think one of the things he said recently is if you're working with one of the big PBMs, you're going to get sued. It's not a matter of if, it's when.
Yeah, let's talk about that. The danger of an insurance company owning a pharmacy benefit manager or PBM. There's some great examples out there.
Yeah.
And the risk of like having that all in one where I'll let you take it from here.
Yeah, it does. You start to wonder about, when's enough or how much is enough in terms of revenue, profit, that type of stuff, when it's coming on the backs of
The
people's
American
health.
worker.
Exactly.
Yeah.
But it's not just the big insurance companies. There are brokers that partner with PBMs, stand up their own relationships, and then give advice to their clients to say, this is the PBM that you should be with.
At inflated rates.
And it's like, well, you've got a conflict of interest. This is a PBM arrangement that you've stood up to benefit yourselves, not the employer.
And it's nearly impossible for the average worker to see through this haze and identify these challenges and pressure their employer perhaps to pick a different plan where I'm not paying 1,000% markup on a drug that I need to save my life.
Again, you're not going to solve the problem in its entirety, but what you can do as an employer is position yourself to have more oversight or be able to monitor those arrangements. If you're getting yourself into a PBM arrangement, for example, that has contractual terms that won't allow you to audit the results.
Wow.
How do you know if you're getting all the rebates you're due, or how do you know that you're getting the pricing and the discounts and such that you were promised in the contract? There's some of the stuff that, again, if you're not paying attention to it, it can put the employer in a really bad spot, especially with respect to their fiduciary responsibilities.
Yeah, that's murky and nefarious.
Yes.
Yeah. Well, Jonathan, it's been amazing to talk with you. If you could just tell us a little bit more about your firm and where people can contact you if they want to find a knowledgeable, excellent service provider like yourself.
Yep. Like I said, I'm part of Plante Moran Group Benefit Advisors. We're looking to help employers that have 50 to a couple thousand employees. If you're looking for creative healthcare solutions, if you're trying to address those 15, 20, 25, 30% increases, we've got some things that we can talk to you about. And you can reach me at my office at 248-375-7475.
Beautiful. Well, thank you for that, and thank you for your time today. I know I benefited from this conversation. I know our audience will love this as well. So thanks again.
All right, fantastic. Thank you.